Hello, everyone. Welcome in, welcome in. Hello to Tanya, Susan, Rachel. Hi, Karen. Hi, Shannon and Desireen. Welcome to our session today. This is our panel on implementation of mobile crisis units and respite services from the peer perspective. And before we jump into the panel, I'll go over a couple of housekeeping items. So before we get started, I want to note that this training is offered through the Crisis and Recovery Enhancement TA Center, the CARE TA Center, which is funded by the California Department of Healthcare Services. Of course, the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the California Department of Healthcare Services. In the case of any security issues, this session will immediately end and will not resume. A separate email will be sent to all participants with further instruction. If you're having any technical difficulties, feel free to post it in the chat. We have our CVent Tech host, Jenny, here to support you, and she is wonderful. I want to give a reminder that everyone's microphones are turned off, and this session is being recorded. If you have any questions or comments as we move through this conversation, feel free to send those questions and comments to me, and I will be happy to uplift that into the conversation. And a reminder, please remember to complete the survey after this session. That's how you can get CEUs, and that's really important for us in terms of just informing our work and how we continue to develop these virtual learning events. And lastly, as you're using the chat box, please use I statements and avoid making any comments that are stigmatizing. Again, the chat box is only open to us as speakers. But yeah, let's all be kind and courteous. And if you need any support for difficult feelings during this session, just a quick reminder that we do have the Feel It to Heal It room available in the attendee hub. That's where you can go to access crisis and warm lines. That's where you can go for supportive resources and even the YouTube playlist that you might have heard if you attended the welcome session earlier today. And so with that, I'll kick us off into this panel. And so I am here with the wonderful Dale Klatzker, who is CEO of Cadenza. And I'm here with Adrian Bernard, who is program manager at Second Story. And some of the questions that we'll be going through today are related to describing the types of mobile crisis units and peer respite services that they have experience with or provided. We'll talk about the unique contributions that peers make to crisis services. We'll talk about recommendations for peers providing crisis care. And we'll also talk about the differences, if they've seen any, according to race and ethnicity of people who access peer-delivered crisis care and among peers who provide crisis care services. And we're going to ask the question, how can peer crisis care best serve people of color? And so with all of that considered, I would love to pass it over to our panelists. And Dale, I believe you're first.
Great, thank you. Good morning to all of you. It's afternoon for me. I'm on the East Coast, but I appreciate you coming and listening to us. So let me start by telling you, I hope you don't consider this to be a bait and switch. And by that, I mean, I am the president and CEO of Cadenza, which is a large addiction treatment provider in the Mid-Atlantic, but I'm not going to talk about Cadenza. I am not a peer. But I have a lot of experience in this area, and I want to tell you about a system of care that I was a participant in prior to coming to Cadenza in the state of Rhode Island. And I think you may find that of interest. It certainly has a lot of touch points with this topic, and happy to talk, about it and give you more information. So let me start. What I want to talk about is the evolution of a system in Rhode Island called the Anchor Recovery Community System. And the Anchor Recovery Community System started with a single recovery, a freestanding recovery community center. Over time, that center and the appendages of that center became the hub and has been the hub of recovery services for all those in need or wishing to participate in the state of Rhode Island. It became the #1 discharge plan for everyone coming out of any kind of treatment program or any correctional facility. That program over the course of a 10-year period has evolved to be not just one community center, but 4 community centers, with some others that aren't part of the Anchor family, but are kind of appendages as well. Of the 3 other centers, one is behind the walls of the state's only correctional facility, so that's relatively unique, and a partnership between the State Department of Corrections in Rhode Island and the Anchor family. One is a partnership with the YMCA, and so it is in a separate building on the campus of a Y in Rhode Island, but it is a wellness-focused service. All of these programs, all of these community centers provide the full array of supports that you would expect, all sorts of support groups, as well as social activities, job training, you name it, healthcare supports. And the third is the outgrowth of the Anchor group creating the first recovery high school in the state of Rhode Island. And what we learned from doing that was that that wasn't enough. And so from that evolved a teen recovery community center for the other hours of the day and week and year. All of these are under that umbrella, and all of these are staffed and run by individuals who are in recovery. Relatively early on in the evolution of all of these programs came the recognition that providing recovery community services was fantastic, but it wasn't enough, and it wasn't early enough. It didn't give us access to the people who we wanted to engage with, so that people had a place early on in their recovery journeys, so that we could reduce harm, so that we could save lives. So we, out of necessity, created some additional services. The first of which, and pretty consistent with what this topic is, was the Anchor emergency room or emergency department outreach. And basically, over a period of time, the Anchor services deployed on a 24/7 basis services to every emergency department located in the state of Rhode Island. These are, again, peer run, peer sponsored. They're available at any hour of the day or night. And depending upon the emergency department and its willingness to engage and participate, peers are deployed after someone has shown up in an emergency room. Sometimes they are called in when an emergency room is notified of someone coming in with an OD, or in a situation where a peer could be helpful. But in either case, it's really an effort to work with family and to work with the individual, to engage them at that critical point, and to make them aware that they are not alone, that there are others out there who have experienced exactly the same thing, and that there is help out there, and that we want to be able to be available to help them. So those are called warm handoff programs now. They're pretty frequent in other states. Rhode Island was one of the earliest, maybe the earliest. I can't, everybody claims they're the first, so who knows? But it's been going on in Rhode Island for a very long time. A lot of consultation has been done with the Anchor program for other states and other areas that want to endorse that. We realized from putting that online that too wasn't enough, because at the point of intervention in the emergency room, people don't necessarily want to engage in anything. So what we realized is that there are too many places that people can fall through the cracks. And to prevent people from falling through the cracks, we added to the ED program a telephone consultation program, an outreach program. So again, 24/7, there are peers available to connect to anyone who we've touched or who touches us. Someone that we might have come across in one of the emergency rooms. We try to gather whatever data or information we can that someone's willing to share with us. And then the telephone consultation follows up. It calls the individual. It calls them the next day. It calls them the next week. It might call them every day. It might call them every week. But whatever is required is done to keep people engaged, to let them know that, again, there is support out there, and that others have gone through what they're going through. That's been a very, very powerful tool in finding no wrong door, really, to people getting what they need. The other evolution over time that has occurred is that we wanted to be less reactive and more proactive. And so in working with the first responders in the state, there was a pretty good data system that evolved, and we were able to trace within pretty much real time where overdoses were taking place, where hotspots were. And so we created, again, an outreach program, the Anchor More program, that could deploy trained peers to go where the action was, to go where the overdoses were, to engage people right where they were when they were doing stuff. And again, it's part of the no wrong door, no wrong way, everybody trying to help do whatever it takes to keep somebody alive and engage somebody in the care that they might need. We know that addiction doesn't discriminate. And that includes, it doesn't discriminate by insurance status. So, it's not just that people who have an addictive disorder or need peer support have no insurance or have Medicaid or have county funds or state funds. It's commercial insurance people also have these needs. And so through the creation of all of these services, the Anchor Group was able to negotiate and build a relationship with Blue Cross Blue Shield of Rhode Island, the largest commercial insurer in the state. And a project was started, and it was actually a research-based project overall, where, again, referral to, access to all of these arrayed services were made available to Blue Cross members. The research component was interesting. It wasn't exclusive to just the Anchor services. It looked at what kept people the most engaged and the most able to take advantage of care. And so what the research would tell us, what the research told us, was that if there was a primary care doctor involved and he or she made a referral to the Anchor services, the outcomes were better. If there was a primary care doctor involved and someone needed and wanted and took advantage of an MAT service and took advantage of the Anchor services, the outcomes for that were even better. So what they found over time was that the combination of these elements provided ongoing support and engagement with people. And not accidentally or coincidentally, they studied, did it lower costs? And during the 3 years, what they learned was that both medical and pharmacy costs decreased by 12% from the initial program engagement. Through some statistical analysis, Blue Cross predicted that there would be a 67% decrease in healthcare costs over the long term for people engaged in this kind of treatment. So that's pretty powerful stuff. And it kind of reinforces the family of services that were developed. How were all these things funded? Well, there wasn't just one funding source, as all of you know, and funding is always a significant issue. These were funded by state dollars. These were funded by federal dollars. These were funded through aggressive philanthropy. These were funded through in-kind services. As peer counseling and peer coaching was recognized by Medicaid and by commercial insurances, it was funded through a fee-for-service mechanism. The Recovery High School was funded through a legislative appropriation. So there really wasn't any one source, but by combining them all, we were able to leverage resources in a way that built a very robust array of care. What are my recommendations? First and foremost, you need to make sure that everybody is well trained and well supported. The work that we're doing here triggers everyone, and a strong support system and a good work-life balance is essential, no matter what you're doing, whether it's one facility or 100 facilities. I have a pet peeve, and I stand on a soapbox, and my soapbox is that I advocate that this is more impactful, can be more impactful if it's done through partnerships. And by that, I mean, in my particular case, I was in Rhode Island, the CEO of a large community treatment provider. We embraced recovery and recovery supports early on. And we felt it was essential for us to put money, put resources, put our weight behind this array of other services that were going on. So my agency did the back office stuff, but we didn't run anything. We supported the operation of everything. And by doing that, you know, sometimes small organizations can get tripped up over things like, you know, accounting and fundraising and filling out, you know, endless amounts of paperwork. That's something that we were used to doing. So we provided that help and that back office stuff so people could do what they were really good at doing. I know there's often a perceived and sometimes a real bifurcation between treatment providers and peers providing recovery supports or respite services or whatever. I think that what we did in Rhode Island and what can be done through this is more powerful. It has more overall long-term sustainability and impact than just either system in separate worlds and separate silos, as most frequently occurs now. For me, you know, we were able to hire, retain peers, give people living wages, give people benefits, retirement plans. We were able to support the scale of the operations. We were able to run around and get federal and state funds. We used our political abilities to promote the importance of recovery. And what I learned from that, you know, so we believe, I believe, that 1 + 1 can equal 3, as opposed to 1 + 1 equaling just 1. And to conclude, I am a firm believer. You know, I've been a treatment provider for almost 40 years. I've run 4 behavioral health organizations in 4 different geographies on the East Coast. And treatment without recovery supports just isn't enough. It's not nearly as impactful and sustainable as if you have recovery supports. Treatment is important. Recovery supports are more important. And you know, my wish is that we find ways of marrying these things so that we have actually a system that helps support people and not separate worlds and camps. So I wasn't on the topic, and hopefully it wasn't a bait and switch, But that's my story and that's my experience, and I know it can be done. Thank you.
Thank you so much, Dale. I really appreciate that. And there was a lot in that, in what you said that really stood out to me. A lot of pieces about partnership. That's something that's really critical. And that's something that I'm kind of taking away as a thread just from throughout this conference. Those really key partnerships with other services, with other supports, that all together complement and provide better care for, the folks who are receiving. And obviously, peer support, peer power is everything. And so definitely hearing that from what you're saying. I'll pass it over to Adrian next, but before I do that, I do want to welcome CAREMHSAinfo in the room. Please correct me if that's not how I pronounce your name. Thank you. Thank you so much, CAREMHSA, for being here. We'll get to CAREMHSA right after Adrian, and so we're so grateful to have you in the room. And I'll go ahead and pass it over to Adrian.
Hello, everyone. Let me just fix the settings here on my computer. There we go. Well, it's kind of nerve-wracking getting up here and talking about things still, but it's also very inspiring and fun. It's great to hear from Dale, and I look forward to hearing from CAREMHSA too. It's been some time since we've talked at NAMI conferences in the past. As said, my name is Adrian. I've been the program manager of Second Story for 7 years and have worked there for 10. Prior to this, I spent 20 years on Social Security, really struggling with a lot of mental health dilemmas, and a couple of those, just to name, not getting too detailed, is I'm a voice here, and I experience plenty of paranoia on a regular basis, but somehow, some way, work has inspired me to move past the stress and to approach it in a different way. Changed my life, really. So Second Story is a peer respite house. This is a place where people can come to avoid crisis, more intense crisis services like the hospital or other residential programs. We are also post-crisis in a sense. We work with people who are coming out of the hospital at times. We also work with people who are moderately in crisis as well, and so we kind of keep the full spectrum of experience. It's a 14 to 24 day stay. You have to have stable-ish housing, sort of like you can have a car or a couch at a friend's place or something along those lines. We work specifically with Santa Cruz County clients who are part of the county system. Often that means they have case coordination. They have a coordinator essentially. Up to 6 people can stay in a 5-bedroom home. During COVID, it was 5, but we really are in a really huge place right now that we were able to buy through a donor, a miracle angel donor, after the program had been threatened yet again with being closed. We work with Encompass Community Services. So this is a provider organization which qualifies us as a hybrid organization, as a hybrid program. Thankfully, it's been a blessing, and I'll get more into that later. We cannot work with people who are on a sexual predator list, and it's self-referred. So somebody calls us up, they go through an interview process. It's interview conversation is what we call it, and then we accept people pretty much almost every time. People can come as many times as they like during the course of the years. And so we built strong relationship, foundational shifting kind of transformational relationships with people, also with people in the system that work in the system. It's 18 and above are the age group that we work with. Some of the services we offer are, we just help people with housing. We'll get people to housing coordinators. We'll get them to housing navigators, other programs that help people get vouchers, Section 8 vouchers. We drive people to the homes to look at places. We do anything we can, help people with computers to make it an easier process. We get people to doctor's appointments, psychiatrists, therapists, primary care, you name it. And we also work more recently with expunging criminal records, taking people to the DA to make that a possibility if people are stuck in the criminal justice system. We go to open mics when open mics are around. We go as a community at times, and just some people sing, some people just listen. We have limited groups, and we have basically one shared meal. Some of our training includes intentional peer support, and Encompass requires motivational interviewing, mindfulness, communities of resiliency model, trauma-informed care. So we do have a full complement of training opportunities that sometimes can be tedious, but at other times it really enhances our productivity in the workplace. So some unique contributions that peers, especially peers at Second Story, have offered to the service providing crisis care system. We've been a bridge, much like Dale was talking about. when we first got here, we were questioned. Providers were afraid of us because they thought we would replace them. They thought we couldn't do it because we were peers. There's a lot of discrimination and a lot of challenge around accepting us. Encompass embraced us and brought us into their work meetings. In every training that we're a part of, the peer voice has been recognized and heard. So as a result of that, a lot of cross-fertilization has happened. Now Encompass is currently talking to me about us being able to, and I petitioned it a while ago, but now they're coming back to it, is getting peers in their workforce so that we have a certain number of peers that are working within residential programs, with the shelter programs, with whatever the recovery programs. We're being recruited now to join the system so that there is a peer presence. I mean, one of my supervisors said of all the residential programs that she supervised, said that she wished that she needed all of her programs to be like Second Story is culturally and how we interact with people. So it's really a great gain. We also, as a result of working with people, guests who come through the programs are now also advocate for themselves more with their therapist, with their psychiatrist, with their caseworker, which has been really a nice side effect to our introduction to the system itself. So crisis is a very interesting thing, and we often, it took us a long time to really catch up with having a stronger policy. In the early days, we were known as a place where hard drugs could be done. So we had to develop a climate and a culture to stem that, because people were not comfortable in such an environment. It was hard for us because we would see we'd be so caught off guard by the traumatic event, or in the stress and the strain and the drama and the crisis, that we don't recognize it immediately, or we didn't. And even now, it's still like a delayed effect. We're so immersed in the experience because we're so close to the people normally, that we lose sight of our own, I don't want to say professionalism, but we lose sight of perspective until enough people are talking, and then we will circle back and talk to people and say, and sort of create limits about what we need and what we want and what we hope for a stronger community. The community mindset is what we cultivate and flourishes here. So some recommendations for peers and who provide crisis services. It's much like Dale said, it starts with the team. I've been a part of every hiring panel since the beginning of the house, and I've insisted that we hire people who come from a background of openly talking about their recovery experience, not afraid to embrace all perspectives. And so it really does become an opportunity. That's something I learned from Soteria houses, that you hire people who love, and it all works out. We got people who can do the work, but it really focuses on that, so that the team dynamics can then cultivate in the house and foster a sense of connection and belonging. And in that spirit of the team mindset is being inclusive of all voices. So at a team meeting, everybody generally speaks. We also incorporate provider input, family member input, guest input, of course. And so the program has been developed by the community, more or less. If there's conflict, something that I've always done, say a coworker is arriving late on time, or not doing as much work on their telephone instead of working with people. These aren't it doesn't come from a punitive aspect from me. I set a precedent of, what does the team group wisdom need and want? So I talk to the person, and then I bring it to the group without naming names. How does somebody feel about timeliness, or about arriving to work on time? And then we have an open discussion about what it means to be in the workplace, and what the group expectations are of being in that workplace. We come together, and so again, the culture of the community defines how we operate as a collective. So the other thing that is incredibly important for me in my work, has been never giving up on a guest need. I mean, you have to, at a point, there is a stopping point. If you've had too much, it's kind of a running joke in my mind about the voices, and I talk about occasionally, and that's maybe a little bit more different than expected, but just never giving up on guest needs unless you've had too much. But peers are so often told that we can't do, that we're not able to do, that whatever obstacle is in the way, we work toward finding solution. And we don't do it for people, but it's just a collaborative process of connecting with people, of really designing what it is a person's expressed need is, and trying to move toward that as full steam ahead. We've enjoyed a tremendous amount of success with this, and we've had some failures. And also, as kind of an example, we've also outscored all of residential in client satisfaction surveys on a regular ongoing basis, we tend to score the highest as well, just the name that it is a successful program in that sense. And so we're building a community and not a program. People's voices contribute to what it is, and we are a restorative environment that people come to. Coordinators come to take a break and talk to us. We also spend time talking about what is important to us, how we want things to be in our lives. And the house doesn't just belong to peers, even though it's a peer respite house. It belongs to the entire community, providers, family members, peers, guests, anybody that wants to contribute in some way can. So I want to throw some demographics at you here, just as a point of just who it is that we're working with. And we have 56% of the first 3 quarters of last year, 56% are European American. And I say European American, I don't say white. It was an old movie in Malcolm X that I saw where it's important to me to say European American. African American folks are 4.5% in the past year. First 3 quarters, Asian American was 9%. Other was 27%. So a large number of people aren't identifying, and the Latinx community made up for 15% of the population of the people in our program. Straight or heterosexual was 54%, 2% being queer, 6% another sexual orientation, and 36% declined to answer. Just want to give you some idea of what group of people we're working with, and also at any given time, the staff itself is made up of 38% to 40%, somewhere around that, of people who bring diversity to the program in whatever way that may mean, through either race, ethnicity, or sexual orientation, or something along those lines. So I think it's important to wrestle with how people receiving services differ from people who provide peer services. I've definitely seen roadblocks for people of color in dealing with the system. I've seen it a lot. I've seen it also with peers dealing with the system also. I've seen it, and I have not had the same. I only know I can recognize it because I've not had the same type of roadblocks, and it can be self-defeating. It is defeating in a sense, and trying to change that is important, and we do work toward changing that. So if the main difference between peer and guest is that peers are on the road to termination. If peer workers are on the road to termination, and if any kind of bigotry is expressed, it's something that Encompass doesn't accept. It's something that just roils within me when things come up. And that said, I've never experienced people who work there offer any sort of discriminatory perspective towards people. Guests, on the other hand, have often have at times had biases, and so we've have made statements that have not been okay, and so that becomes a conversation at that point, and setting a boundary, and our community guidelines are brought forward, and we talk about what happens. So what we do is also, I found that the people who have been offered the most bigoted statements, and I hope that's not a bad word, forgive me if it is, but have been people of European American ancestry, and so it's been a conversation with those folks as well. So how can we as peers provide best serve people of color in our workforce? I mean, and in our community? It's been primarily through communication. We have a shift change group 4 times a day, and various topics come up over the course of time. What it means to be a peer in the system, what it means to get out of the system, what it means to be a person of color in the system. What does racism mean? What does sexism mean? All of these things become open for conversation, and they become deep, and they become powerful, and they become profound toward the healing. I think the most beautiful aspect of Second Story is when people walk in the door, they drop the mindset of that they're a peer, or at least they're welcomed into a community that they no longer had to game over. There's no longer a game being played. We're all in this together, and our lived experience shares the common ground that we work toward. So it's a matter of celebrating difference. And so some of the things that we do we have a spirituality wall where we have all this religions up on the wall. We work toward creating awareness around holidays as they come up. We truly really try to incorporate the connectivity of our community. It's been really a gift to be a part of this house, to see so many lives transformed, and people of color have offered so much acceptance towards each other, and as have European Americans too. I mean, we really have created this beautiful dynamic of harmony in the place that does its best to watch out for each other and to protect each other and to serve each other. And so, and I just want to close by saying that just by what I said earlier, that this program, this community does not belong to the peer movement, to the peer community, and it does, but it belongs to the entire Santa Cruz community, to providers who contribute, to family members who contribute, to even the county workers who fund us. Thanks to peer certification happening now, we're on solid ground again. But I will stop there and thank you for your time, and I appreciate all that you're bringing here today, and have a great day.
Thank you so much, Adrian. You spoke a lot about, concepts related to inclusivity and creating community. And I appreciate your statement in particular on how, when people go there, there's no game. So much of the challenge of racism and its persistence is that it's essentially always a game that people are trying to get through, to navigate, to one up. And so kind of creating a space where there is no game, that resonated with me. So thank you for that. And with that, I want to pass it over to CAREMHSAinfo to go through some of these same questions around services provided, unique contributions of peers to crisis services, recommendations you have for providing crisis care related to peers. So I'll pass it over. Thank you for being here.
Okay, thank you. Hi, I am CAREMHSAinfo, and I'm located in the unceded land of the Tongva and Chumash people, who have been stewards of this land for generations, which other people might call Los Angeles, California, just so you know. I don't know if we have anybody who has low vision, but if so, I have long black hair, I'm wearing black glasses, a turquoise necklace. I'm sitting in my room in which there are different types of pictures in the back that I can't even see. So I can't tell you exactly what they say back there because they keep changing. So I'm happy to be here and to help identify myself and center myself with you all. I want to start off with just a brief statement about my personal story, so it can be understood why it is that I do this work and how I got called into doing this work. So I'll just start off here. And by the way, this ended up being testimony for Cory Booker on a judicial subcommittee hearing on police reform and behavioral health crisis response. Cherry red 1461 Doc Marten Oxfords. I wanted those shoes forever. I saved up my pocket change until I could finally afford them, bought new outfits to match them, and wore them nearly every day, and survived a life-altering, horrific experience in them. That terrible night, the voices would not relent. Terrified and too embarrassed to call my mom, I reached out to my doctor. Surely he was a neutral resource that I had trust that he could get me out of this untenable situation. I was in trouble and I needed help. My doctor quickly responded saying that he had to call 911 for a welfare check. I had been repeatedly told that a mental illness is like any other physical illness and should be treated as such. So when I was told that, there was going to be a 911 call, I thought the ambulance or EMTs would come. That's what I thought was going to happen. Well, that's not what happened. The police came to this very small apartment building that I was living in and knocked very loudly at my door saying, welfare check, this is the police department. And all sorts of things were running through my head. As an African-American, I actually wondered what my neighbors were thinking. I was the only Black person in the building. Were they thinking that somehow I had committed some criminal act? Secondarily, I was wondering, would I even be safe to answer the door given the many horrific outcomes for African Americans and police interactions? So that kind of paranoia didn't stem from my mental illness. It actually stemmed from the realities of what it's like to be Black in America. I'm not going to go into what happened that evening, the rest of what happened that evening, but just think handcuffs, police cars. It was a lot of drama that seriously didn't need to happen, but that drama led to me having a lot of trauma about wanting to even interact or receive any kind of mental health services, whether I was in crisis or not. So, some of the work that I ended up doing eventually was working at a peer-run program under Mental Health America, Los Angeles, called Project Return Peer Support Network. And we took that program from being a $90,000, I think about a $90,000 budgeted program into being its own nonprofit. And when I left after about 5 years, I think we were between about $5 million. One of the things that I really wanted to ensure that we did was not always be reliant on government funding, which really puts a lot of restrictions on what you do, but also to look at diversifying the kind of funding that we had and the type of services, supports, resources, and training that we could offer. The other thing, and I think MHALA did a great job of this, so I didn't really have to do a lot in this area, but also made it an intentional thing, is to ensure that staffing was as diverse as Los Angeles County. Los Angeles County is huge. It could be its own state. It really could. I'm glad it's not, and that we haven't split off from the rest of the state, but it is very large, of 10 million people and over 440 square miles of land that can be desert, rural, urban, so it's really a lot to try to meet the needs of about 10 million people, if you will. So we had a variety of programs that included a Latino a peer-run and family-run center, El Centrito de Apoyo in Un Paso Mas. Also, we have and they still have these programs, they're no longer there, but they also have a warm line that is also offered both English and Spanish. While I was there, we opened a peer respite. And thanks to folks that like Adrienne and others at Second Story, what we did is we went and we visited other peer respites in order to figure out how would we set up our peer respite. What we decided with the peer respite in Los Angeles County was to site it within a community that had a lot of already services for people, particularly who experience homelessness, called Villages of Cabrillo. And that was with intention because we found a lot of people in crisis were also in crisis because they were at risk of, like, on the edge of, or technically homeless, living in their cars. I mean, that would be technically considered homeless. So we wanted to make sure that we could connect people to housing supports and resources while they were also in respite care. The other thing that we also did was ensure that we had family peer supporters as part of the team, so that we not only had people with lived experience as peer supporters, we also had family supports for families, because if a person is going back to their family, we wanted to make sure that the family understood what is a peer respite, and also how can they support their loved one if they're moving back into the home. The other thing we did is we had coffee and donuts for police, which seems a little oxymoronic after my weird experience with police. But the reason that we did that is we wanted them to understand completely who we are, what we did, how we did our work, that we could also be a place where they could come, relax, and kind of decompress and take care of their own emotional wellness. Hurt people hurt people. So we didn't want police to be hurt and then hurt other people, especially ours. So actually what happened is, if calls came for the police to come to the peer respite, they knew what we did and they could refer the calls elsewhere. So they were not the responders. So it was really an intentional kind of thing there to develop that relationship. We developed relationships with hospitals, so hospitals could know to refer, so that people can do the pre-registration. So it would make it easier when they would come to the respite, that they could come straight away without having to go through a long registration process. And a lot of times people would end up at the hospital not needing that level of care, and hospitals might not have any other place to send folks. So by creating that relationship with hospitals, it made it easier for them to say, okay, no, not here, but we've got this respite. So that's some of the things that happened at the peer respite when I was there. Again, I don't work there right now, but it does still continue. It was open during the pandemic because it was in a large enough setting that not social, but physical distancing could be maintained and people could remain safe while being at the respite. Work I do now is with the Mental Health Strategic Impact Initiative, and I've been working on crisis and crisis reform since the 988 federal legislation and states working towards implementation. And so in that work, we actually worked with the DEAD Foundation, the Center for Court Innovation, Hayward Burns Institute, and Fountain House. I was like, I know I'm missing somebody, Fountain House. And we created a document called From Harm to Health, Centering Lived Experience in Race Equity and Crisis Reform Services. So that says it all, what it was about, that we can sit here and we can have 988 legislation, we can do the implementation that at the state level, and then look at what it looks like at the community level, but without doing that centered on the lives of people with lived experience who have had experience with these services, experience with crisis response, and then crisis response systems. We may be creating stuff, that quite frankly, can I say the word sucks? Am I allowed to say that? Stinks, okay? So we really want services that will meet our needs when and where and how we need them, rather than thinking everything is mobile crisis response to get you to a hospital or into treatment. That may not be what the person needs at the time. And also to make sure that peer services and family services, that folks have the training to provide that support. In the work with Harm to Health, we also had judges involved and law enforcement involved. And it was really interesting that the police officer who was involved when we started talking about utilizing psychiatric advance directives, she didn't know what one was. We told her what one was. We told her how to offer one to someone, how to ensure that the system of care was aware of what they are and to use them and to offer them. She was furiously taking notes. It was like, okay, got it. Now what I'm going to do is I'm going to go back. We're going to train all our officers. We're going to go back to the mental health system and the substance use system, make sure that folks know what a psychiatric advance directive is, know that we are going to be asking for them. We're going to keep the forms on hand on the iPads in our cars, and also hard copy forms, so that people can now start to develop. It's like a wellness recovery action plan, but a psychiatric advance directive, of course, has a legal statute for people to follow them, so that they can help people prevent use of services and police interactions that may not be needed when somebody is in crisis, that people can make their needs known, and those needs need to be followed when you have a psychiatric advance directive. So police know to ask for one so that they can follow what it says in it for the person. And also if the person doesn't have one, to offer one and know who the resources are, peers who will help them either complete a RAP plan or a psychiatric advance directive. So long story short, I think there are a lot of things that we could be doing to ensure that people of color, people with lived experience, and their family members are part of it is really a wave going on at the federal and state level in which we could be involved in informing the implementation, the programs, and the evaluation of what the 988 and crisis systems will look like, especially to counteract a lot of the harmful and deadly effects of police involvement and other unwanted involvement in crisis response. So I'll end there.
Thank you so much, Karis. There was a lot there that you said too, but something you mentioned that I think both Dale and Adrian had spoke to is the importance of partnerships and relationship building, whether it's with law enforcement, whether it's with health systems, hospitals, And I'm wondering if any of you, Adrian, Dale, Harris, could speak a little bit more to that as well. Like, where are there areas for improvement in terms of building partnerships? Who needs to know more about respite services, or who needs to know more about peers providing crisis care, and how can they get involved? How can they do better? Or how, on the flip side, how can peers do better to connect outward to those services? And any of you can jump in.
Yeah, so the reason that I was late is I just got off a call with CMS and they can only be in listening mode. They cannot provide any response or say, yes, we will do that, or no, we won't. But it was about 6 people from the Center for Medicare and Medicaid Services around 988, the 988 legislation and crisis response systems. And what is the role of people with lived experience from communities of color, and what are the role of peer and peer respites, how to have guidance from CMS that there be expectations of their involvement in any of the planning and implementation moving forward, as well as funding for peer services throughout the continuum of care, including peer respite. So I think those are some of the things like, how do you find out what's happening at your state level, and how do you get involved in the planning at the state level? And if you do Google like 988 and state implementation, you'll find out the lead for the state 988 implementation. And or you can go through like CAMPRO, California Mental Health Peer Run Organizations. Any of your state peer organizations may also have that information, as well as NAMI and MHA.
So I'd love to say to you that people will intrinsically partner with each other and that people will do the right thing, but that isn't what happens. And that when you're in an environment where there are scarce resources, people fight over the resources that exist as opposed to mobilizing to demand more resources. That said, there's a phrase I learned a long time ago that is that the way to herd cats is to move the food dish. And if we move the food dish, similar to maybe what Karis is talking about with the 988 or other things, the power of how we fund things will leverage and maybe require people to partner in ways that they don't currently do it. There's a lot of fear about that. There's a lot of distrust, but ultimately it's going to take something significant to move people away from their own self-interest into the greater interest, I think.
Thank you for that. I really appreciate that perspective on it too. And I wanted to speak a little bit more to the last question that we included on the prompts on, any differences that we see in outcomes for by race, by ethnicity, or perhaps by other communities, by gender, sexual orientation. And I wonder if any of you can speak to how your services have been augmented, or how you've considered that and taken that consideration into perhaps data, or perhaps the implementation or planning of services.
So I'll be first because I'm not a service provider, so
Okay.
I can't answer that. So I can't answer the question. but I can say, as people are providing services, this is exactly the work they should be doing, is really parsing down the data to understand exactly where the inequities happen, and then to look at, are the inequities structural, historic, and institutional in nature? And if so, I think in the peer world, we do a lot of advocacy, yes, and we try to support people in their recovery. And this is one thing I think is really important to think about as we're supporting people in their recovery. I'm just going to say this, and I hope it is not one of those things that I get smacked for later, is making people of color feel good about living in a society that really doesn't work for them, I don't think is a good way to go. It's a start because we have to live in that society. I don't want to be resilient against this in a society that's all about racism. I don't want to be resilient. I shouldn't be resilient. It means that society gets to stay the same and I have to change to meet the needs of this, crap ass society. I'm not okay with that. So I think one of the things that we can do as a service, as a peers and advocates, is also, as we're helping people live the best they can in this society, is to also address the things that's causing the oppression that then causes the trauma and the illness. I think that's part of our job too. And looking at some of our data can help us understand where those inequities are happening. And again, the institutional and systematic things that are causing that oppression and illness.
I mean, I don't think there's no easy solution here, obviously. But I think there has to be a dialogue, there has to be honesty, there has to be a development of relationship and trust, and there has to be intentionality to ultimately move the dial even slightly. There is so much discrimination and so much stigma in our world and in our society on so many levels. People in recovery are discriminated against. People of color are discriminated against. People of color who are in recovery are discriminated against twice as much. It is layer upon layer of problems that we all have to stand together and try to fix, but it's got to be intentional. We got to work on it.
And I'll just add that it is changing, and as any kind of experience that as humans, it takes, the long road is generally one we're on, but I see the changes. The changes are painful for a lot of people, and I think how can we recognize and support each other through this transitioning towards a better consciousness. I'm hoping that the changes bring a better consciousness for us all. And there's no guarantees. Humans are humans.
I'm going to add one other quick thing. I'm a certified personal medicine coach, which is a program through Pat Deegan and Associates. And what I really appreciate about the work that she does is that it evolves as issues and needs kind of arise around developing what's called personal medicine, which is there things that you can do to impact your own wellness versus things you can take, for example. And, she has added to her array of personal medicine cards, I will name the oppression that, causes whatever distress, and this is what I will do about it. So I really, really love that it's acknowledging that oppression can cause anxiety, depression, paranoia, but there's also things that you can list in your personal medicine that you can do about it that you won't many times be doing on your own. You'll be doing it collectively with other people. So I just think it's so fantastic. I just thought about that she added that to the work to address oppression. Thanks.
Thank you for sharing that. Where can we learn about that? Is there a resource that we can go to?
Yeah, actually you can go to, you can Google Pat Deegan, personal medicine coaching or coach. It's on her Common Ground website. I'll pop it in the chat, Ayana, and then, okay, great.
Thank you. And as we're coming to the last minute here, I want to thank all three of you, Dale, Adrian, and Karis, for taking the time to come today, share your stories and experiences and, provide this important information to the audience. I know I've learned a lot, so I'm really appreciative. For everyone in the room, please don't forget to take our survey. That is how you get CEs for this session. And of course, that's just how we get information that we will take with us and continue to improve upon our events. So definitely take that survey, and I'll see if I can drop the link in the chat. I don't know if Jenny, you have a link to that you can provide if you're in there. If not, you can hold 1 second and I'll make sure I get this to folks. 1, 2, and 3. Here we go. Oh, there it goes. Thank you, Jenny. And thank you, Karis. I see that you just posted this in the chat. I'll make sure that this resource gets out to everyone. There we go. Thank you all so much for being here. The links are in the chat. Go ahead and complete that, and we'll go ahead and close out the session right on time. Everybody go and enjoy your lunch.